Okay, so I figured that this month, given that everything is still pretty hectic, especially on the floors, that we would go over a topic that just isn't really as difficult to follow or to understand, and just kind of go over observation medicine and what it is and why it exists in the first place. And we'll talk a little bit about documentation requirements and a couple of other things at the end that are a little bit more boring, but at least in the beginning, I just wanted to go over so everyone has a really good understanding of why it exists at all. So we'll talk about the purpose and some background information. Why did it come to be? A little bit about finances, because you have to really understand the financial implications of observation to have an understanding as to why it exists at all. What patients are best for the OBS units and who are not, and some of the metrics that we look at to measure if our observation unit is functioning optimally. All right. So what is observation medicine? So CMS has a definition that is a well-defined set of specific clinically appropriate services. It's really long. We're going to skip ahead. Pretty much it's further testing and or treatment while determination is made to decide if a patient needs to be admitted to the hospital for further workup or if they can be safely discharged home. So it's kind of that in-between space. So RE2 is observation. For those that may not know, maybe from the emergency room, RE2 means Rapid Evaluation and Treatment Unit. It's just a fancier way of saying the observation unit. Patients in observation are not admitted to the hospital, so we don't admit patients to observation. They're actually in outpatient status, so it's more of an extension of the emergency room. So what is it? The actual medicine is internal medicine, but more at an emergency medicine pace. So a very high turnover. The patients that we're seeing are not going to be staying there very long. So when we're working in the ER, we're working in minutes. The floors, it's usually days, and observation is hours. And just to give some, yes? Okay. This may be a little bit of redundancy for those that work in the OBS unit often, but I also want to just make sure I included a little bit of information so that the ER providers on the video are able to have a little bit more understanding. So I apologize if it's redundant for some of our RE2 folks, but you need a team and you need a lot of buy-in from everyone in the hospital. So your provider team is going to be a nurse practitioner or PA and an attending. Some places you work, it might be staffed by residents or just attendings. It depends. But I think that most of the models that I've seen nationwide are APPs along with attendings. Case management has a big role. As you all know, there are the case managers in the emergency department. And also we have case managers at Morningside that is specific to the observation unit. And down at West, the case manager will cover the ED along with the OBS unit. Social workers are very important. As you know, we get a lot of social cases in the observation unit. So they're just an integral part of our team across the board. You need nursing staff that understand observation. So ideally, the nurses that are working in the observation unit have a really good understanding of everything we're talking about today, just the high turnover, not being surprised when all the patients are discharged home every day, just really having some buy-in from them as well. And then hospital administration. You need an administration that supports an OBS unit and understands its importance and makes sure that all of the other departments across the board are also making sure that the OBS unit is prioritized. So we work closely with a lot of other departments. As you guys know, chest pain, syncope, CHF, those are some of our more common diagnoses. So we work very closely with cardiology at each site, and also neurology, I'd say, is also someone that we talk to somewhat frequently for the TIA patients. Radiology needs to be on board to make sure our tests are expedited, sometimes IR, and then obviously working very closely with everyone in the emergency department. So it's pretty much everyone across the board needs to understand the time constraints and make sure that everything is getting prioritized for the observation patients over inpatients. So I'm not going to go into this in detail, just in case you were wondering, there are 4 types of observation units out there, type 1 to 4. The best units are protocol driven and those that have dedicated units, meaning a specific space that the patients go to. So, we have an observation unit at each hospital at Morningside and West, but some hospitals might have what they call a scatter bed model. So a patient might be somewhere on a random floor in the hospital, but in observation status. And as you can imagine, this just really isn't that efficient because, the nursing staff, the social workers and everything are their other patients are inpatient. So it doesn't function as optimally. And then by protocol driven, what that means is there a written protocol for each diagnosis that you would take in the observation unit? So my goal is to get to be a fully protocol driven unit. I think that we pretty much function in a way that a lot of the patients get similar care for certain diagnoses, but the best units really are fully protocol driven. So my goal will be to get us there, but that takes a lot of work with other departments to make sure that they agree with the protocols that you've written. So last time I showed you guys the TIA protocol and pathway, and I think that will be the first one that we have coming out. I did finally get some more feedback from the emergency room. So I'm hoping that'll be coming by the time the OBS units open up again. But the goal will be to have a protocol for every diagnosis. Okay. So why do we have OBS units at all? If any of you have ever worked with me, it really just comes down to money and finances, and hospitals needing observation units to be able to get paid for some of the patients that were staying in the hospital. So I'm skipping this slide, but it's only because I have it again later. We'll go over all the details there. So the reason this came to be is because CMS made this 2 midnight policy back in 2014. So it pretty much said that if a patient's expected to stay in the hospital for 2 midnights, then they can meet inpatient criteria. And that was kind of how this all came to be. So the hospitals, CMS got tired of paying for patients that are only there 1 day, a full inpatient admission, because these are bundled payments. So the hospitals were like, we're not getting paid for these kind of patients. What are we going to do? So then that's how observation status and observation medicine came to be. So they needed to get paid for these patients, but had to figure out a way to do it outpatient. So what did this rule do? So it decreased the amount of improper payments for short stays. And then, I'll talk a little bit about the second point. If patients are in observation inappropriately and they should have been admitted, then the patient might end up with a higher bill. So the goal of this was also to decrease that. And also the goal was to just streamline this across the board to make sure that all the hospitals are kind of following the same rules and doing the same thing so that they could standardize the process a little bit more. So they updated it in 2016. They realized that there were maybe some cases where they should be admitted and the hospital should get paid for an admission, even if they're not going to be there 2 midnights. So for some of these inpatient only procedures, so obviously someone comes in with appendicitis, you're not going to put them in the OBS unit and get surgery there. That's someone that will be admitted to the hospital and the hospital will get paid for that diagnosis. So certain inpatient only procedures. Obviously, if you intubate someone in the emergency room, you're not putting them in an OBS unit. So if they're intubated, then they also will meet admission criteria and can be admitted even if they go home the next day. So that might be the case for someone who's acutely intoxicated and you're worried about them protecting their airway. Sometimes they get intubated, and then maybe we'll go home the next day. And then if a patient dies before their 2nd midnight or they leave AMA, then the hospital can still get paid for those admissions. If the patient is in observation and then they are transferred inpatient, but then they go home the next day, the midnight that they were in observation plus the midnight that they were inpatient all bundles into one inpatient bill. So that's important to note because these patients will end up meeting inpatient admission criteria, and the hospital will get paid for the full time. So it's not, I know sometimes when we say, well, we're going to admit the patient and they're like, well, they're doing well, they're almost better. Why don't we just keep them in OBS till tomorrow? The reason is because they meet criteria and the hospital should be paid accordingly, because an inpatient admission for anything, asthma, COPD, is going to pay probably 3 or 4 times more than an obs stay, and they meet the criteria. So that is the better thing for the hospital across the board, and also the patient. And I'll tell you why it's better for the patient financially in a couple of slides. I have some examples. So I apologize. This is really boring, but it's one slide. And I just want everyone to have a little bit of an understanding, because without understanding the Medicare payment, it's kind of hard to really be able to explain to patients anything. So Medicare Part A is for inpatient hospitalizations. Medicare Part B is for outpatient services. And this is what observation falls under, is Part B. And then Part D is their prescription coverage, which might cover some of the medications that they get. But the most important thing is to understand that it's Part B that's outpatient services. Some patients might have these questions for you either while if you're working in the emergency room, or even after they come into the obs unit. So it's kind of good to just understand the difference there. So what is the cost to the patient? Because I feel like this is a very common question that we get. And there's a lot of misinformation out there, especially in the media when it comes to observation medicine. So for inpatient stays, if you look on the left side, the hospital is Medicare will pay the hospital based on a DRG, which is a diagnosis code. So for someone who comes in with a STEMI, there's a specific DRG, and that the hospital will get paid this bundle payment. The patient has, as of this year, about a $1,500 annual deductible to Medicare. So that could be what the cost is to them for that inpatient admission. If they're in observation, then Medicare pays for 80% of whatever their total bill is, and they pay 20%. And you're like, I don't know what that means. Let's go through some examples. So this data is a little old, so probably the costs are a little higher across the board to account for inflation. But let's look at chest pain, because that is the most common thing that we see. So Medicare costs, which we don't care as much about, but this is important just to understand kind of the hospital finance side of it. If a patient comes to the observation unit with chest pain, if they are admitted to the hospital will bill about $4,000 to Medicare. If they're in the observation unit, they will bill about $1,300. Now, if you go to look at the cost for the patient, if they are admitted, they will probably have about a $1,000 bill towards that annual deductible I just mentioned. But if they're in the obs unit, it's $340. So that's obviously much more beneficial to the patient to have that payment structure. Now, if you go and you look at the top, that same patient, say that they're admitted with chest pain and they end up having an uptrending troponin, and cardiology does decide to admit them and take them to the cath unit, to the cath lab, and they have a stent inserted. Now the hospital will get paid about $13,000. If this is all done in the obs unit, the hospitals will get paid about $5,000 less. But if you go over to the patient costs, they will get charged about $1,000 towards that annual deductible. But if they're in the obs unit, it's about $1,700. The reason for this is because the patient will get a separate bill for the procedure in addition to observation stay, because it's not part of that bundled payment. So when you have a patient in the observation unit that you're trying to do too many things and also billing for procedures, the patient's going to get a bigger bill. So one, they meet admission criteria and the hospital will get paid the amount that they should for that diagnosis. And two, the patient will end up with a much larger bill and probably be pretty upset about it down the line. So across the board, it's better for the hospital and the patient that they end up in the right place from the emergency room. Or if they're in observation unit and the patient, cardiology is like, we just want a cath, they'll probably go home. It's why we always say, no, they have to be admitted to the hospital. Okay. So there are studies out there that have looked at the cost to patients. And so I just wanted to make you aware of them in case you are asked about this. You're like, I don't know, Bonnie told me that the patient gets paid, has to pay less. There are a couple of things out there that you can actually reference. There was a study or an Office of I forget, the OIG report back in 2014. Pretty much what the goal of this report was is they wanted to look at Medicare beneficiaries and see if they were paying more for inpatient versus obs. And they found that 94% of observation visits resulted in a lower cost to the patient than a short inpatient stay. The other 6%, when they looked into it further, were usually patients that just weren't appropriate for observation to begin with. And then what about commercial insurance, patients that have, anything across the board, Blue Cross Blue Shield, Oxford, those kind of things. So the American Journal of Emergency Medicine did a retrospective analysis for, I think that's 7 years. And what they found was the mean total cost of medical costs across the board was about 41% more for when the patients were admitted to the hospital. And the cost to the patient for the admission is actually about 33% more. So they found the same thing, that the cost to the patient is actually much better under observation as long as it's the appropriate disposition for them. So this kind of says the same thing. What this graph is from that last article that I mentioned, that in the blue line is the percentage of patients from the emergency rooms that across the nation that are getting admitted to the hospital. And you can see from 2008 that there is a steady downtrend of admissions from the ER to the hospital. And observation, there is a steady increase. The increase in observation doesn't account for the total decrease in admissions to the hospital. It's actually a bit more. And the reason is because I think that the more hospitals that have observation unit, the more likely the ER doctors are going to feel comfortable keeping the patient in observation as opposed to sending them home. Because if you don't have the option of obs, then obviously there's nothing you can do. But if like a patient comes in with chest pain and they're in immediate risk and you can't guarantee follow-up, you'll put them in an obs unit if you have that option. So as observation units are more mainstream, more patients are ending up in obs units, which just makes sense. We don't have to go into this. The whole reason I even included this is just to show that there is a steady increase of costs across the board, whether you're inpatient or observation, and this generally just goes along with the natural progression of inflation. Okay. So who should go to the OBS unit? You guys all know that the exclusion criteria is out there. It is in Epic under the Documents tab if you're logged in on the ER side of Epic. And it's also available for both sites in the Re2 Quick Tips form. So there's a link at the bottom there. But the ideal OBS patient is a patient that you see that you expect is going to be able to either go home or at least a decision is made about if it's safe to discharge them within 24 hours. They should have a low severity of illness. They should be pretty low maintenance. The reason being is specifically in our units, the staffing, we don't have, it's a lower nursing ratio and there aren't as many techs. So we can't take patients that are on one-to-one or behavioral disturbances because we just don't have the staff to really account for that. And if they have multiple acute conditions or are too complex, then they likely meet admission criteria. So they're not really an ideal patient for observation. This is the exclusion criteria. I'm not going to go into it in detail. I just wanted to have you, be familiar with what it looks like. Obviously, if they're hemodynamically unstable or septic or acutely intoxicated, they're not going to be ideal for our OBS units. One thing I did want to point out, because it's something that I get questions on a lot, is from the social standpoint, what can we do in observation and what can we not do? So across the board for basic social work needs, like the patient maybe would benefit from a home health aide referral, or maybe they have a 24-hour home health aide and it's 3 in the morning and you can't send that patient home from the emergency department, then it might be okay to put them in the OBS unit just for the social worker to help arrange that the next day. But if a patient has been declining over a couple of days and can no longer walk and they're too weak, the likelihood of them being able to walk and not need to go to subacute rehab is quite low. So across the board, a lot of the payers require that the patient is in the hospital inpatient for 3 midnights to go to a subacute rehab facility, or if they just need long-term nursing care, so that's what we call a SNF, a skilled nursing facility, then they need 3 midnights inpatient. Observation does not count towards that. So if it's during the hours where there is a case manager, a social worker in the emergency department, it's good to get them on board early so that maybe this determination can be made based on their payer mix if observation is possible. So sometimes at West, we have a little bit of a better payer mix down there with commercial insurance. They might be able to place a patient in a subacute rehab facility from observation, but it's incredibly rare. So only really if the case manager looks at their chart and says that this is someone that we might be able to, we can try it. But otherwise, it's it's better to admit that patient, because if they're in observation on, say they go to observation unit on a Monday at 4 p.m., the next morning they're seen by PT and they say subacute rehab, that Monday night doesn't count towards these 3 inpatient midnights, unfortunately. It's a silly rule. Hopefully that'll get changed at some point, but that's what it is right now. The only caveat to that is with COVID, some of the payers have waived this 3 midnight rule. So it's possible that when the OBS units open back up, there might be more patients that we can do this, but I don't expect there to be. Okay, and the only other thing I wanted to mention from our exclusion criteria as to why we even have this on there is if the observation stay is expected to be under 8 hours, then the hospital can't bill for it. So it has to be over 8 hours or more to get reimbursed. So that's why if you look at the exclusion criteria, there might be some things that seem a little weird, but anemia, and I specifically have uncomplicated patients that require only a single transfusion, may be discharged from the ER. And the reason for this is 1 unit of blood only takes 3 or 4 hours. So putting them in observation is, we're not going to get paid for it. It's better to just discharge them from the emergency room if it's safe to do so. Okay. So I just wanted to go through, just to let you know kind of what I do and my job as the medical director and things that I'm looking at and the metrics that we measure to see how the units are functioning. So we look at the average length of stay. Like I said, the goal is no more than 24 hours. The percentage of patients that are in observation that end up being transferred inpatient versus how many are being discharged. I look at how many patients were able to avoid a potential inpatient readmission, because that's really important for the hospital. If there's an RRT or a code, then obviously I'll review those cases. We look at bounce backs, so people that bounce back within 72 hours. And then obviously working alongside the ED providers and providing feedback about dispositions whenever there's something that maybe would have been better inpatient, or if someone even ended up inpatient that could have gone to OBS, just kind of providing that open feedback. All right. This is kind of old data because COVID, obviously our census has been all over the place. When we expanded our exclusion criteria back a few years, it did increase the amount of patients we were having in the OBS unit, which decreased the amount of denials that the hospital received of 0 to 1 day admissions. So it was beneficial for the hospital across the board. And this is Morningside, sorry. For the transfer inpatient rate, the expected rate is about 20% if you have a simple OBS unit, which simple OBS units are usually more ED based. So they take like a certain, just like only chest pain, syncope, mild cellulitis. Maybe they have a very small subset they take. But ours are more complex observation units. So we do take patients that are a little more complex than maybe they would take in others. And you can accept up to 30% transfer inpatient rate. So ours kind of oscillates around that, in the upper 20s to lower 30s. We won't have to go into that. Okay, so in summary for this part, and then I'm going to talk a little bit about documentation, very little bit, but I just wanted to go over the pros and cons of observation across the board. So the pros, and there are multiple studies out there that prove that observation decreases patients' length of stay and cost across the board. So if a patient with chest pains admitted to the hospital versus placed in observation, they're going to have a decreased length of stay with the same level of care and decreased cost. So across the board, it is beneficial for most diagnoses. It improves resource utilization by allowing to have this accelerated treatment protocols. Usually patients, they're going to be happy. They're able to get in and out faster and have the, whatever the question is answered in a quicker way. And it improves the throughput of the entire hospital. So these patients aren't in inpatient beds needlessly. And then the con, which I mentioned before, if you overutilize observation, it can lead to increased cost for patients and that have these prolonged length of stays and have complex diagnoses. So something to always keep in mind when determining what the disposition is going to be for the patient. Before I move on, I just want to ask, I can't see the chat, but are there any questions about anything that I mentioned there before I talk a little bit about billing? No. Okay. All right. So as I mentioned before, observation status is really a billing status. And I'm very briefly going to touch on this. This obviously is going to apply more to those of you that work in the observation units right now. But when the hospital submits a bill, and to be fair, honestly, I did not know any of this before I became an attending. But when the hospital submits a bill to insurance, they are submitting a facility bill, which is what the hospital is getting paid for everything, and then a professional bill, which is what the physician bills. The hospital is getting both payments, but they are separate bills that are submitted. So I'm not going to go in the basics because you guys are not going to be submitting bills, but I just want you to be aware that the professional billing is what the attendings are putting in Epic when they sign the notes. The facility bill, what the hospital gets, so this is based on a comprehensive APC. What does that mean? It's based on the diagnosis code, and it's a mini DRG. So inpatients are DRGs, and observation is kind of like a smaller little bundle. So it submits one bill to the insurance company that has to cover all of the labs, all of the ancillary services, all the radiology, whatever you do for that patient in the observation unit is going under this one bill. And that's really important because the more you do, the less the hospital's going, the less revenue the hospital will actually take in. So the comprehensive APC for observation, last I checked, was close to $2,400. So any labs that you do, any x-rays you do, whatever you give the patient is coming out of this $2,400. That's why it's best to, if you don't need it for this observation stay, like you don't need an A1C for someone coming in with asthma, anything that should be done outpatient should be done outpatient, because otherwise you're going to decrease the revenue for the hospital and you're going to end up running an observation unit that's functioning at a deficit. So it's really important to minimize what you do in an observation unit across the board. And this also includes consults services. I'm not going to go into this in detail. I made a slide that I will send out the slides and you guys will have access to this lecture as well on our website. But there are 3 levels. There's low, moderate, and high complexity you can bill for. If a patient's in an OBS unit, the likelihood of them being low complexity is minimal. It's probably just someone who's there only waiting for like a home health aide to pick them up. Most patients are going to be moderate or high. So whenever you are documenting a history and physical, you have to include family history along with the past medical and social history, or you cannot bill for above a low complexity. So it's really important. Always, always, always include a family history. And you can't say not contributory. You can just say, no diabetes or something along those lines, but you have to put something there to be able to bill for it. And just as a general rule of thumb for RE2 H&Ps, make sure it has all 3 of those elements and just include 10 review of systems and 10 physical exam, and you'll meet those requirements every time. So obviously your assessment and plan doesn't have to be that detailed. It can be just a very short treatment plan with goals of observation. So if it's an asthmatic, continue steroids, nebs, reassess. There's not much more you have to say there. And then if there's a change in their status, obviously put a progress note in just because that's good documentation anyway. For the discharge summary, it has to include a discharge physical exam to be able to bill for it. So just always remember to include that in your note. And I just wanted to show you that if you aren't including these things, the best you can bill is the low acuity, which is this 135 here on the left. And just this example down here shows that if you end up having to bill 2 as low acuity versus 2 at high acuity, you've lost about 40% of the revenue. So it's important to always include those things, and then you're always billing appropriately. I already covered this, that if a patient was initially in OBS and then it meets inpatient criteria, then their entire stay will be rolled into this inpatient DRG. And then CMS just specifically has a statement that says this. So I wanted to just include it so you guys have access to that there for reference. Okay, and that is what I have here. I know I promise my lectures moving forward are going to be more interactive, kind of like our last one, but given that like about half of the people said, listen, I'm too burnt out, I wanted to keep this pretty passive and just make sure that at least I got some information to you this month. So do you guys have any questions, anything you want me to clarify? You can also email me if there's something that you think of down the line.
Thanks, Bonnie.
Thank you.
Thank you, Bonnie.
Thank you. That was a great lecture.
Oh, you're welcome, guys.